Okay, so in this video we'll be talking about the neurodegenerative disorders in pediatrics. Let's start by looking at the things that we're going to discuss. First of all, we'll talk about the types of disorders, whether they're hereditary or acquired. Secondly, we'll go into those disorders themselves: sphingolipidoses, neuronal ceroid lipofuscinosis, adrenal leukodystrophy, mucopolysaccharidosis, mitochondrial diseases, Rett syndrome. Then we'll talk about degenerative diseases with focal manifestations, and finally we'll talk about the mimics of neurodegenerative disorders. Right. So there are two types of disorders which we are going to discuss, or which will broadly classify all these neuronal degenerative disorders into. The first one is hereditary or metabolic. What that means is we have a disorder which is either inherited or it is a condition which is metabolic. That means it affects the entire body at once. On the other hand, we have other diseases called acquired disorders, which are diseases which the child was not born with, but later on in life acquired it. Now, the hereditary or metabolic illnesses can be further divided into two types of illnesses. Firstly, we can classify them into gray matter disorders, and the second way to divide them is into white matter disorders. The gray matter disorders can also be called neuronal disorders, while the white matter disorders can also be called leukodystrophies. There are certain features which are specific to neuronal disorders, while there are certain features which are specific to leukodystrophies. So for example, in neuronal disorders, what's more prominent are early seizures and intellectual impairment. While in leukodystrophies, signs which are more prominent are upper motor neuron signs. So that could be spasticity, increased reflexes, and white matter lesions. There is a way to diagnose them, which is you can see cerebral white matter changes. Now keep in mind that most of the disorders that we're going to talk about in this discussion are going to be hereditary or metabolic. So basically all of these disorders are metabolic or hereditary, only the mimics are acquired. So the concepts that we talked about here of being neuronal or leukodystrophies can be applied to most of these disorders. So now that we understand that, we can then move on towards discussing each of the disorders individually. Let's start off by talking about sphingolipidoses. So what are sphingolipidoses? These are a set of disorders in which there is an abnormal accumulation of sphingolipids in our body. Sphingolipids are a normal part of the cell membrane of cells in our body, especially the brain. Whenever there is abnormal breakdown of these sphingolipids, we then end up with accumulation of these products. So they're part of the cell membrane, and as they're broken down, this is where you can see the sphingolipids as part of the cell membrane, and they're normally degraded into sphingolipids, which are then recycled and used by our body. But whenever there is abnormal degradation, abnormal breakdown of these lipids, we then end up with accumulation of the products, and these products can be toxic. Other than that, there are some features that you need to understand about sphingolipidoses. Firstly, most of them, you'll notice, are autosomal recessive. There's just one disease which is X-linked, but we'll talk about that when we come to it. But remember that most of them are autosomal recessive, and that infantile forms are more severe. That means if the disease starts presenting towards the older age groups in the pediatric age group, you'll know that they won't be as severe as compared to the disorder if it presents quite early in life during the infantile period. Now this is a diagram which is crucial to our discussion of sphingolipidosis. This is the normal sphingolipid degradation pathway, which means that the final product of sphingolipid degradation, as you can see, is ceramide. If there is any problem in reaching this final product, we can end up with a sphingolipid disorder. What disorder that is depends on what level of this diagram the defect is. And throughout our discussion, we will refer to this diagram here to make sure we understand the subject. So let's start our discussion by talking about the first disorder in the list, called Niemann-Pick disease. From this diagram, what you can see is that if this pathway of sphingomyelin to ceramide is blocked, the substance which will be increased will be sphingomyelin. So we'll take this knowledge and we'll move on to the disease itself. So Niemann-Pick disease. Niemann-Pick disease has a couple of features which we should be aware of. The first being hepatosplenomegaly. So the liver and spleen will be enlarged. On the other hand, there is another feature which is characteristic, which is cherry red spots in the retina. The mutation that results in this is called SMPD1 mutation, and the enzyme which is deficient is sphingomyelinase. So if sphingomyelinase enzyme is deficient, you have sphingomyelin increase. So in this diagram, it is at this point that sphingomyelinase would be acting. If at that point sphingomyelinase is not acting anymore, you will end up with increased sphingomyelin. The next disorder that we're going to discuss now is called Tay-Sachs disease. In Tay-Sachs, you can see that the problem is in the conversion of GM2 to GM3. So whenever that happens, you will have increase in GM2. You will have accumulation of GM2. So we'll take that knowledge with us and we'll move on to the features of Tay-Sachs disease. So there are a couple of features to Tay-Sachs disease which are specific. Firstly, cherry red spots. Now you might ask me, cherry red spots are present in Tay-Sachs and they're also present in Niemann-Pick disease. So how do we differentiate? Well, the differentiating factor between these two is the lack of hepatosplenomegaly in Tay-Sachs. There is no enlargement of the liver and spleen in Tay-Sachs. Other than that, we have intellectual retardation of the patient as well in Tay-Sachs disease. On top of that, we can also have something called a marked startle response till the age of 6 months. What is the enzyme that is deficient? It is called hexosaminidase, and this results in increased GM2 ganglioside as we saw in the diagram mentioned before. So the next disorder that we have to discuss now is called metachromatic leukodystrophy. In this disorder, the conversion of sulfatides to galactocerebroside is deficient, is problematic. So in this case, what is the compound or what is the substance that will be increased? Sulfatides. Easy. So remember, this pathway, sulfatides to galactocerebroside, is problematic in metachromatic leukodystrophy. And now we'll see what is the enzyme which is deficient in this case, which is causing the accumulation of sulfatides. So now we'll talk about some of the features specific to metachromatic leukodystrophy. Firstly, ataxia, which is a gait abnormality. Secondly, we have spasticity of the muscles. Thirdly, we have intellectual deterioration. And next, another important thing is if this is the eye and if this is the optic nerve, you will have optic atrophy. All the features that you see throughout the Sphingolipidoses are because of the accumulation of the toxic metabolites in the cells and outside the cells, and these result in the problems that we see as clinical features. The enzyme that is deficient in this case is called aryl sulfatase A, and this is the enzyme which is responsible for carrying out the metabolism of sulfatides to galactocerebroside. And if that is deficient, we have increased sulfatide accumulation, which is toxic. In this case, in metachromatic leukodystrophy, one of the treatment options which can work is bone marrow transplantation. So the next disorder that we have to discuss is a disorder called Krabbe's disease. Krabbe's disease is not mentioned on this diagram, but the pathway which is affected is mentioned on this diagram. Can you guess where it is? It is this pathway. It is the changing of galactocerebroside to ceramide which is affected in Krabbe's disease. And so you end up with accumulation of increased galactocerebroside in your body. So now we'll talk about the clinical features of Krabbe disease. First of all, the patient can have seizures. They can also have blindness. We'll have irritability, as well as upper neuron lesions and lower motor neuron lesions. There are certain type of cells which are seen on histology in a case of Krabbe's disease. These cells are called globoid cells, and if mentioned, this would be an indicator towards Krabs disease. And what is the enzyme which is deficient? It's an enzyme called galactocerebrosidase, which is basically an enzyme which converts galactocerebroside to ceramide. So if the enzyme is deficient, you end up in accumulation of galactocerebroside in your circulation. So the next illness on our list is called Gaucher's disease. As you can see, in Gaucher's disease, there is a problem in the conversion of glucocerebroside to ceramide. And this, we'll see which enzyme is involved and what are the clinical features specific to this now. Okay, now we'll talk about the features of Gaucher's disease. In Gaucher's disease, you can have hepatosplenomegaly, pancytopenia, bone pain. Opisthotonos means it is a painful backward arching spasm of the muscles, especially of the head, neck, and spine. And since our muscles in the back are stronger than the muscles in the front, you end up with this position where you have this arch, a backward arch of your body. This is also, you might have heard about this from tetanus. Another feature is trismus, which means that the muscles of your mastication, which are involved in chewing your food, undergo intense spasm, resulting in locked jaw. Your jaw is basically shut really tight. Another clinical feature that we can see is eye movement problems as well. You can remember it by understanding that even the eye muscles can be involved in the spasms that are happening in this disease, and those can result in eye movement problems. The enzyme that is problematic in this case is called glucocerebrosidase. Don't confuse this with galactocerebrosidase. This is glucocerebrosidase. Another name for this is also called beta-glucosidase. And whenever we have a problem in this enzyme, you end up with increased accumulation of glucocerebroside, and especially in the liver, bone marrow, and spleen, which can explain the clinical features that we just saw. So the final sphingolipid disorder that we're going to talk about now is something called Fabry's disease. You can see from this diagram that Fabry's disease is because of problematic conversion of ceramide trihexycide to glucocerebroside. So if you have a problem in this pathway, you will obviously have an increase in ceramide trihexycide. And now we'll take a look into this illness. So Fabry's disease. In Fabry's disease, you can have some tumor-like masses called angiokeratomas on your skin. You can even have paresthesia of the peripheral limbs. And the enzyme that is deficient is called alpha-galactosidase A. And this results in ceramide trihexycide accumulation in your tissue, just as we discussed with our diagram. Okay, now that we have finished discussing sphingolipidoses, we will move on to the next list of disorders, which are called neuronal ceroid lipofuscinosis. To understand this, you must understand first what is lipofuscin. Lipofuscin is a lipid protein which has a pigmented appearance, and if it's not degraded enough, you end up with accumulation of lipofuscin, and this results in the disorder, and this results in the clinical features that we find in lipofuscinosis. The first sign which usually presents in these patients is visual loss and obviously can cause blindness. Other features that we can have with this is something called progressive dementia. Patient has memory loss. The feature which we can have in lipofuscinosis is seizures as well. And how do we diagnose this illness? On diagnosis, there are two enzymes which are usually problematic. The first is PPT1 and the second is TPP1. You must realize that both these enzymes are involved in the degradation of lipofuscin. So if you have a defect in these enzymes, you end up with decreased degradation of lipofuscin and increased accumulation of lipofuscin. The next set of illnesses we're going to look into is called the adrenal leukodystrophy. From the name itself, you can understand that other than leukodystrophy, it also involves now adrenocortical insufficiency. So the key features that you must understand is that we have neurodegeneration like before, but on top of that, we have adrenocortical insufficiency as well. It's important to remember as well that this disorder is X-linked. Unlike many of the disorders that we have been learning up till now, it is not autosomal recessive, it is X-linked inheritance. So this diagram basically tries to show you what the normal function is which has been disrupted in the case of adrenal leukodystrophy. Let's start with the idea of peroxisomes. These are peroxisomes. Peroxisomes are structures in your cell which break down very long chain fatty acids into smaller structures so you can use them for whatever purpose they are needed. Here is the very long chain fatty acid. It has been transported into the peroxisome where it has been broken down by the enzymes present within the peroxisome, and so those fatty acids can then be utilized by the cell. Now, ABCD1, let's name this gene. ABCD1 is a gene which codes for this red protein here that you see. This protein codes for the channel which transfers very long chain fatty acids into the peroxisome. Now, if this channel is defective because of this gene mutation, you will end up with accumulation of these very long chain fatty acids in especially your adrenal cortex, in your central nervous system, and testes. And that is what results in the symptoms in adrenocortical insufficiency. So now we'll move on to the symptoms. As I said, the very long chain fatty acids cannot be degraded anymore, so they accumulate in the adrenal cortex, testes, and CNS. In the adrenal cortex, this results in symptoms of fatigue, hypotension, and vomiting. In testes, this results in gynecomastia and hypogonadism. And in the CNS, it results in the neurodegeneration. To diagnose adrenoleukodystrophy, you can perform an MRI, and on that MRI, what you will see is white matter destruction, especially in the parieto-occipital region of the brain. Another form of adrenoleukodystrophy is something called adrenomyeloneuropathy. From the word myelo, we can understand that we are referring to the spinal cord. So in adrenomyeloneuropathy, we also have the involvement of the spinal cord as well as the peripheral nervous system, and it usually presents in the third decade of life. Now, the next set of illnesses we're going to look into are called mucopolysaccharidoses. So the general concept is kind of similar to what we have been discussing up till now, except that the structures involved are quite different. So again, the cell is shown on the left. This is your normal cell, and it contains structures called lysosomes. Now, within these lysosomes, you find hydrolases. Hydrolases are enzymes which are supposed to break down substances. Now, in this case, the substance which is not being broken down anymore is called mucopolysaccharides, right? So these mucopolysaccharides cannot be broken down within the lysozyme, mainly because you have a deficiency of the lysosomal hydrolases. You have the deficiency of enzymes which are normally present within the lysosomes, and so you cannot break these mucopolysaccharides. And these mucopolysaccharides then accumulate in your body, and they result in the symptoms. And the symptoms that we have in mucopolysaccharidoses are mainly related to the organs in our body where mucopolysaccharides are more. So what are these organs in our body where mucopolysaccharides are found more? Are bones, cornea, connective tissue, tendons, cartilages. So wherever these mucopolysaccharides are more prominent, we end up having the symptoms. In bones, this results in kyphosis. In cornea, mucopolysaccharide accumulation results in corneal clouding. In connective tissue, for example, the face, you end up with coarse fasces. Two examples of the illnesses of mucopolysaccharides are Hunter's syndrome and Hurler syndrome. In the differentiating factor between these is that in Hurler's, you have corneal clouding. The disease is generally more severe, but in Hunter's, there is no corneal clouding, and the disease is generally less severe as compared to Hurler's. So once we're done with mucopolysaccharidosis, we'll move on to the mitochondrial diseases. So, as you might already know, mitochondrial diseases are always inherited from the mother only. And since mothers pass mitochondrial children, not the father, that is the inheritance which is responsible in mitochondrial diseases. On top of that, you might already know that since the mitochondria is also known as the powerhouse of the cell, it is here that oxidative phosphorylation happens, which is the process by which energy in the form of ATP is generated, right? So a defect in the mitochondria always results in a defect in the ATP formation, and so whenever our body goes through a stressful situation, ATP is required to deal with the stress, and thus in times of stress, like infection or fasting, the lack of ATP results in the symptoms of mitochondrial disease. Now there are a couple of them. We'll discuss them one by one. This is a mnemonic for it, MELAS syndrome. What MELAS stands for is myopathy, encephalopathy, lactic acidosis, and stroke. There are two more. There is MERF. MERF stands for myoclonus, epilepsy, ragged red fibers. And what's NARP? NARP is neuropathy, ataxia, retinitis pigmentosa. The next illness we're going to look into is called the Rett syndrome. Now the key feature in Rett syndrome, which we need to remember, is the regression of developmental milestones. So what that means is that if the patient gained a developmental milestone before, for example, the patient was able to stand up and walk, now the patient will go back to crawling. This is something which we refer to as the regression of developmental milestones. So the patient will lose the communication skills, the gait skills, the hand movement skills that they previously developed. And in these patients, you can also have something called acquired microcephaly. And the mutation which results in Rett syndrome is known as the MECP2. So the next illness that we're going to discuss, next set of illnesses that we're going to discuss, is called the degenerative diseases with focal manifestations. Two diseases which come under degenerative diseases with focal manifestations. First is Wilson disease, you might have already heard about that, and the second one is subacute necrotizing encephalomyopathy. We'll start off by discussing Wilson disease. In Wilson disease, your basal ganglia is affected, right? So basal ganglia is normally involved in the regulation of purposeful movement, and so a defect here results in tremors and dysarthria, dystonia. If you check the serum of the patient, what you will find out is that the patient's ceruloplasmin levels are low. What is ceruloplasmin? Ceruloplasmin is the protein which carries copper in the blood and stops it from getting deposited in our organs. If ceruloplasmin is deficient, copper roams around freely in the blood, resulting in deposition in the cornea, in the basal ganglia, in the cerebellum, in the liver. So as long as ceruloplasmin is present, the copper is bound, it is unable to drop everywhere that it likes. But if it's free, it is much easier for it to just deposit in the various organs in our body. And the treatment for Wilson disease is something called oral penicillamine. The function of oral penicillamine is similar to the normal function of ceruloplasmin. So what oral penicillamine does is it binds to copper and it stops it from depositing all over, just like ceruloplasmin would. Next disorder we're going to discuss is the subacute necrotizing encephalomyelopathy, also known as Leigh disease. In this disorder, we have the mutation in the mitochondrial DNA. And what this results in is again oxidative phosphorylation defect, which again results in lack of ATP, and again you're unable to deal with the stresses which our body faces. You must remember that primarily the region of the brain that it affects is called the periaqueductal area, especially in the region of the brainstem, the cerebellum, and the caudate. What this results is in the symptoms of respiratory irregularity, extraocular movement defects, ataxia. These are the defects that it can result in. Now, if you check the blood of the patient, what you'll find is that the patient's lactate and pyruvate levels are elevated, which makes sense because if you remember that mitochondria uses oxygen to perform aerobic respiration. And aerobic respiration cannot be carried out now because your mitochondria is not functioning properly. And so anaerobic respiration starts happening, and lactate and pyruvate are part of the anaerobic metabolites. And this is what happens, and this is what gets accumulated. Finally, there are some diseases and illnesses which can mimic inherited neurodegeneration disorders. These include epilepsy, especially if it's not controlled well, chronic drug use, heavy metal intoxications, especially lead. A feature to remember in lead intoxication is irritability. We can also have vitamin deficiencies, like especially the B1, B12, B3, and vitamin E. We can have congenital hypothyroidism. Structural brain diseases like hydrocephalus can also mimic these illnesses. We can have brain infections like measles, which can cause subacute sclerosing panencephalitis. We can also have psychiatric disorders, which can mimic neurodegenerative disorders. Okay, so that's about it for the discussion. If you found it useful, go ahead and leave a thumbs up. subscribe to the channel, and share with anyone you think will find it useful. Until next time then.